So, good evening. We are starting another session of our YouTube class today, which is a series on emergency medicine. So, we won't be dealing much into the details of emergency medicine, but the common things which, as a practitioner, which we should see, which we should assess, and which we should never forget. Okay, so before going to basic topics as such, how will you deal with the case of emergency medicine, or when you are in the casualty? What are the basic things you should know? Basics of assessment in emergency medicine. So the thing is, compared to a routine assessment, which we do in OP or ward setup, assessment in emergency room will be different because patients will be sick. They'll be emotionally unstable. The relatives also will be emotionally unstable. So going through a routine pathway like history taking or clinical examination will not work. So we need something called as targeted approach. So assume a patient comes with any complaint to the emergency room or casualty. You must be able to ask a targeted history, either from the patient or the relatives. And you should do a targeted examination because doing a detailed examination may not be possible most of the time. Even trauma comes under emergency. So doing a targeted examination is important. Some say that the most important thing, even before asking these things, is assessing the vitals. So suppose if you feel that a patient is not stable by means of vitals, or he is looking obviously unwell, you are supposed to do a complete vital checkup, that is blood pressure, seeing the respiratory rate, saturation, pulse rate, and assessing their consciousness level. And in trauma cases, sometimes we may have to look at their disability, or that expose them to look at any trauma. So in such cases, doing that may be important than taking a targeted history. And history may be taken by yourself or by your assistant at the same time while one person is stabilizing the patient. So this is one aspect. At the same time, while you are doing a targeted history, target examination, and vitals, this forms the component of assessment. While the assessment is going on, immediately the other side should focus on resuscitation. So in emergency medicine, both assessment and resuscitation should go hand in hand. So assessment, resuscitation is not something very dramatic. It is basically simple, like accessing lines. So establishing IV access, giving back rest to a patient. Just giving a back rest or giving a cardiac table to the patient may be a simple measure to relax the patient. And starting oxygen, or plan for starting non-invasive ventilation, or planning for intubating the patient. So this comes under airway access. And just giving a fluid to the patient who is in shock may be a part of resuscitation. So all this should go side by side. So once your assessment and resuscitation has been completed, and you feel that the patient is improving, then you can go for a more focused secondary examination. Or suppose if the patient is worsening, then your resuscitation should continue. At the same time, by this time, at the end of the basic assessment and resuscitation, you'll be having a diagnosis in your mind so that the next steps can be easy to follow. Okay, so this is just an outline. So with this background, I think we'll go to the topics one by one. I think we'll start with one topic, which is assessing respiratory distress. So basically, many people will discuss emergency medicine like cardiac emergencies, metabolic emergencies, respiratory emergencies. But I feel it will be good that if you assess by the symptoms, like patient will not, you won't have an idea whether the patient is having a cardiac symptom or respiratory symptom when he comes to you. You only will be knowing about the symptom. So when the patient comes to you with respiratory distress, so what are the things you will be doing? So we'll go from the vitals as such. So you feel that the patient is dyspneic. So I think respiratory distress will be very obvious. The patient may not be able to lie down. He may come in a sitting position. His respiratory rate is high. So from a distance itself, we can obviously see. So what are things we can pick up in the vitals initially? Or we'll keep it like this. So when do you say patient is in respiratory distress? One, he's having a high respiratory rate. So we say normal respiratory rate is 12 to 20. So when his respiratory rate is more than 20, we say he's in respiratory distress. He's obviously using his accessory muscles of respiration. Okay. He's using his accessory muscles of respiration. And or sometimes he may even be in a drowsy state with his respiratory rate high. Then comes your saturation. So now, as you know, the normal saturation will be more than 95%. Suppose it is less than 95%, then you can tell the patient is in distress. So blood pressure may be normal or low or high. It could be anything. So why I'm stressing this, why I'm keeping saturation as the last point in respiratory distress is a patient with a normal saturation can also come with a breathing difficulty. Okay, so he may use his accessory muscles of respiration. His respiratory rate may be high. He may be unable to lie down. He may be coming in a sitting position, but still his saturation may be 100%. So that is why it is important. So to us, tell that a patient is in respiratory distress, saturation alone is not the criteria. So have a general look at the patient. Look at his respiratory rate, his accessory muscles, and you can look for any cyanosis. So overall, these things will give you an idea that the patient is in respiratory distress. Okay, so a patient has come to you and you have done all this examination. I'll give you a few set of vitals and we'll go and proceed. For example, assume that the patient's BP is 130/80. His pulse rate is around 117 per minute. You have seen the saturation, it is around 96% in room air. And his respiratory rate was around 30 per minute. So clearly he's in respiratory distress. But as I told you, the other vitals are not so high. Pulse rate is elevated more than 100. Saturation is a bit in the lower range, but not in the critical range. Less than 95 will be considered critical. So this is the first step. You assess the vitals. Patient has come to you. As I already told you, assessment and resuscitation should go together. So you are given the bed to the patient. You are kept a backrest. So this is the basic resuscitation. You are kept a backrest. And in emergency, any patient with respiratory distress invariably start oxygen. Right? So this is the basic resuscitation or immediate thing. And at the same time, you have to start IV line. Maybe 1 or 2 IV lines is okay. And take the basic blood investigations. Okay. So then comes the aspect of targeted assessment. So suppose the patient is able to give a history or you are able to speak to the attenders, just ask a targeted history. So in a case of respiratory distress, what are the specific history you will ask? First thing is the onset, progression, and duration. For any history, especially in emergencies, you just ask the OPD history, onset, progression, and duration. So whether it is a sudden onset, he was up normal till 10 a.m., then suddenly he developed a breathing difficulty. That is sudden. Or it could be, it could develop over hours. He was normal till 6 p.m. today. Then gradually over the next 4 hours, he developed a breathing difficulty and now he is distressed. So over hours, maybe like 2 to 3 hours. Sudden is over minutes, seconds to minutes. So that is over hours. Or it is chronic, slowly progressing. He had that breathing difficulty over 5 to 6 days and now it is severe. So this duration is very important in breathing difficulty. So what is the onset, progression, and duration? So that is very important. Second thing is try to ask their prior comorbids. In emergency medicine, always it is better to present any case rather than telling the primary diagnosis. Try to tell the comorbids first because they will help to give a diagnosis. For example, a patient coming with respiratory distress, if they have a comorbidities of diabetes, hypertension, coronary artery disease on medications, then their probable diagnosis will be different compared to a patient who is a chronic smoker COPD patient comes with fever and breathing difficulty. Both will be having different diagnosis. So try to ask their prior comorbid. So for example, any patient who's a known case of bronchial asthma or a COPD, or who like if they are not labeled as bronchial asthma or COPD, anyone who gives complaints of recurrent wheeze or respiratory infections, mostly this goes to a case of respiratory medicine. Respiratory causes of acute respiratory distress. Suppose the same history, they are telling a history of coronary artery disease or uncontrolled hypertension or diabetes or any previous history of stenting or cardiac bypass surgeries. They are present with a breathing difficulty, then probably this is a respiratory case. It's a cardiovascular case. Of course, in old age, both can coexist. A patient who is having a cardiac comorbidity can come with a respiratory distress, a respiratory cause of a respiratory distress. But at least in the initial setting, we can try to isolate them, whether it is a primary respiratory or a primary cardiovascular, because your treatment will and your approach also will vary. So I think second thing. And third thing, you can ask about the associated symptoms. Associated symptoms, in addition to the respiratory distress, what else they have? Like, did they have any chest pain? As you know, chest pain will be either anginal type or a pleuritic type of chest pain. So did they have an anginal type of chest pain? So a side note, when do you say it is anginal type of chest pain or a typical angina, just remember 3 points. Retrosternal. We'll discuss this again in chest pain also, but I'm just mentioning here. Retrosternal compressive type of chest pain. This is point number 1. Point number 2, which is aggravated on exertion. Third point is relieved on rest. So the presence of these 3 features make up chest pain, anginal type of it. And that is, it is a cardiac type of chest pain. At the same time, chest pain which is over the axilla. A chest pain which is more lateral or in the axillary region. It is not a compressive, but it is a stabbing type of pain. A stabbing type of pain, which is more on respiratory movement. Respiratory movement in the sense more on deep inspiration, more on coughing. This will be a pleuritic type of chest pain. This will go towards a respiratory cause of chest pain. Okay, so whether it is an anginal chest pain or a pleuritic type of chest pain. Then you can ask about palpitation. Palpitation mostly points towards a cardiac. Presence of syncope or loss of consciousness. This also mostly points towards the cardiovascular. Of course, there's the overlap also. Then you can ask about history of leg swelling, pedal edema. Presence of edema also points towards the cardiac cause. So on the contrary, as I told you, presence of a pleuritic type of chest pain, in addition to breathing difficulty, points towards a respiratory cause. And presence of a cough, presence of expectoration. It could be a mucoid expectoration or a purulent expectoration. Any expectoration, presence of wheeze. Remember, breathing difficulty and wheeze both are 2 different symptoms. In wheeze, patient typically tells that they have the whistling sound or noisy breathing. Yes, so all these things and hemoptysis. So please note this slide because breathing difficulty, anginal type of chest pain, palpitation, syncope, edema, these are the typical 5 cardiac symptoms. Whereas pleuritic type of chest pain, cough, expectoration, wheeze, hemoptysis with the breathing difficulty. These 6 are the cardinal symptoms of respiratory system. So we'll be definitely will be asking the same questions in any patient coming to the OP also. But in emergency medicine, it is very important that you ask this history very rapidly so that you can quickly classify whether the cause of respiratory distress is a cardiac or a respiratory. Of course, patients have respiratory distress even without any of these symptoms. He could have just a plain breathing difficulty without any of these symptoms. This complaint will be just a breathing difficulty. I don't have any cough or expectoration, or it could be an unrelated symptom, an abdominal pain plus breathing difficulty, abdominal pain plus breathing difficulty. So in that case, we cannot fit it into cardiovascular or respiratory. In that case, you have to look for a few other things, which I'll tell you, which I'll tell shortly. Okay, so in targeted history, from the either patient or attender, ask their onset, progression, and duration, ask their prior comorbidities so that we can have an idea, and ask their associated symptoms. I think these three is the basic history which is needed. And after this targeted history comes the targeted examination. You can't go and do a vocal resonance or vocal frequency in a patient with an emergency. So I'll just tell you what are the things you have to do an examination. So already vitals have been discussed. So in targeted examination, what you can look for is few things in general examination. You can look for cyanosis. You can look for pursed lip breathing. Because pursed lip breathing is something which points towards a disease called COPD. Pursed lip breathing. And maybe you can look at the position in which the patient is sitting. Position of the patient. Because if the patient is able to lie down, mostly we can rule out cardiac cause as a cause of breathing difficulty. Because as you know, in patients with cardiac cause of breathing difficulty, they'll be having pulmonary edema, they'll be having difficulty in lying down due to orthopnea or PND. They'll be comfortable sitting down in the leaning forward position. So if the patient is dyspneic, but he's able to lie down, then mostly it is not cardiac. There could be some overlap, but usually this is the thing. Suppose if he is comfortable in a sitting position, tripod position, then he can think of cardiac. Of course, there's an overlap also. Tripod position also occurs in respiratory. This is just a screening. If he is not able to lie down, or any patient is brought in a stretcher who is not able to lie down in a comfortable in a sitting position, I mean fairly comfortable in a sitting position, then the first thing which should come to your mind is cardiac cause. And okay, so what are the system examination you will definitely do? Obviously, the first thing we have to look for is the respiratory system. I think trachea should never be missed. Okay, maybe you can palpate the trachea to see whether the trachea is midline or it is deviated. Because if it is deviated, we'll have only 2 or 3 diagnoses in our mind. One, it could be pneumothorax. Usually pneumothorax which presents in emergency will be called tension pneumothorax. We'll discuss it shortly, but tension pneumothorax or a massive pleural effusion. A small pleural effusion will not come to the emergency, whereas a large, sudden onset of pleural effusion will come to the emergency. Accumulation of fluid in the pleural space is called pleural effusion. Suppose in trauma, the patient has the same breathing difficulty, suspect blood in the pleural cavity, which is called hemothorax. Right? So pneumothorax is air in the pleural cavity, pleural effusion is fluid in the pleural cavity, hemothorax is blood in the pleural cavity. So pneumothorax, pleural effusion, hemothorax, there will be deviation of the trachea to one side, opposite side. If there's a right-sided pleural effusion, there will be deviation of trachea to the left side. This is one. And collapse. A right-sided lung collapse will cause pull of the trachea to the right side itself. So these are the conditions causing acute respiratory distress and changes in the trachea. Usually we miss in the heat of the management. So I think never miss trachea because these 3 diseases are commonly missed. Only these are picked up after someone does a chest X-ray or when a senior consultant comes. If you see the trachea first itself, I think you won't miss these things. So the next thing you have to do in an examination is look for air entry in both sides, which is part of the respiratory examination or respiratory system examination. Look for air entry in both sides. So if there is air, so many of us have a tendency when we keep the state, we look for whether V's is there, crackles are there. It is wrong. First thing, always look for whether air entry is present in the both sides. So I suggest that you can see the respiratory examination in the following order. In both infraclavicular region, you can auscultate. That is both the apex of the lung, both the infraclavicular region. Then in both infraaxillary region, you can auscultate, which is the lateral aspect of the lung. And in the both posterior aspect, you can auscultate. Base of the lung, posterior of the base. So it is enough if you keep in these 6 places. Okay, so both the infraclavicular region, which will give you an idea about the apex of the lung, both the axillary region, infraaxillary region, again, some pleural effusion or pneumothorax will be better picked up if you keep your step in this region. And the posterior aspect. So these 3 places in both sets of the lung will be sufficient for your. So look for air entry in both sets, whether all these 6 areas have equal air entry. If in one side there is reduced air entry, then suspect a pleural effusion or pneumothorax that side, or there's a collapse on that side. So assume, I'll give you just a short scenario. Patient is having a absent breath sounds in the right side. Okay, absent breath sounds in the right side. But the trachea, as I told you, trachea is shifted to the left side. Then only you have 2 diagnoses. Either it is a pneumothorax or a massive pleural effusion. Because I told you, trachea will be shifted to the opposite side in the case of pneumothorax or pleural effusion. So whereas in collapse, there will be absent breath sounds in right side, trachea also will be shifted to the right side. Right? So what I want you to understand is look for air entry. That is the first thing we have to look for in a breathing difficulty. It is not the added sounds. The third thing you can look for is added sounds. Only you have 2 added sounds which are very important. One is wheeze. Other one is crackles. Maybe I'll tell you one more finding which is called stridor. Some textbooks say small differences. That is, wheeze is different, rhonchi is different, stridor is different. But from an emergency medicine point of view, any whistling sound or a continuous sound in the lung will be wheeze, or it could be stridor. Whereas crackles is an interrupted sound or a wet sound. Like the bubbles, when you blow bubbles through a glass of water, then the sound is called as crackles. So just a small difference between wheeze and stridor. So you'll be hearing whistling sound in both places. Try to auscultate the trachea also. Trachea, just above the sternum. Suppose if the sound is more in the trachea, the wheeze is more in the trachea, then it is mostly called as a stridor, because stridor is nothing but a sound which is produced due to obstruction of the larger area, that is the trachea. Whereas wheeze is also a continuous sound, but it is produced due to obstruction of the smaller airways like bronchi or bronchioles. So in wheeze, you will be hearing the musical sound more in the lungs or the chest, whereas in the trachea or the suprasternal region, you will be hearing the sounds better, which means it is stridor. Just a small technical difference. You will not be employing this technique most often. Like mostly you will be labeling a patient as having wheeze. But in few situations, identifying a stridor is very important. For example, a patient who's having a swallowing difficulty plus a breathing distress, it probably goes to an ENT complaint. Patient may have a laryngeal tumor, which is obstructing the trachea. At the same time, it's obstructing the food passages. So patient may have a swallowing difficulty and a breathing difficulty. Any patient who has consumed a corrosive acid poison, in that case, only the throat, the larynx and the pharynx will be affected. So we'll be having more of a stridor than a wheeze. So in these cases, I think looking for stridor is very important. So why to identify stridor early is the treatment of stridor goes to ENT. They may do an emergency tracheostomy to open the trachea and help them breathe better. Whereas in wheeze, our routine medical management, bronchodilation, nebulization, etc. Right. So in our examination, we have seen the trachea. We saw whether the air entry is equal in both sides. We look for any added sounds. Then the and so where does crackles help? Usually, I think presence of crackles in the lung points towards either 2 diseases. One, it could be a pneumonia or a ARDS respiratory cause, or it could be a pulmonary edema. So they say fine basal crackles is pulmonary edema. And then the fourth thing is you have to look for the cardiovascular system. So again, patient will be in tachycardia due to the respiratory distress. It may be difficult to appreciate every small murmur and everything. Just try to identify. You are here able to hear S1 and S2. Because if you are not able to hear S1 and S2, heart sounds are muffled, then you may be dealing with a case of pericardial effusion or cardiac tamponade. This is also a condition where patient will come in respiratory distress. So whether S1 and S2 is heard or not, that is the first question. If it is heard, like it's enough if you tell that if it is heard, because you may not be able to appreciate the character of S1 and S2. Another finding which is very important in cardiovascular will be identifying S3, which is nothing but the third sound. The presence of third sound usually points towards a heart failure. Murmur identification will be very difficult, but by experience, maybe you may be able to pick up some murmur. Like a patient who's a known case of cardiac disease or a valve disease, he comes with breathing difficulty, maybe you can appreciate a murmur. And if possible, try to look for the regularity. So usually you would have picked up the pulse rate, whether it is regular or not in the initial vitals assessment itself. But still, even in your cardiac examination, you can look for whether pulse is regular or not. So I think this completes one aspect of respiratory distress, which is targeted examination, targeted history. So all this, I think, should be done within 2 to 3 minutes. Right? Any doubt still here? If no doubts, we'll proceed.
No, sir.
Yes. Hello?
No doubt, sir.
No doubt. Okay. So patient has come. We have assessed the vitals. So in our patient, we are given a back rest. We have started oxygen. We have started the IV line. So remember, I gave you a scenario. Patient's pulse rate was 117. His BP was, I think, 130, 80, I mentioned. It was within the normal range. His saturation was only 95. And his respiratory rate was 30. So after the targeted examination, targeted history and examination, we came to know that he is a 68 years male. He was a known coronary artery disease, was taking clopidogrel and aspirin. Clopidogrel and aspirin for a long time. He's still regular with his medicines. And he did not give any cough or expectoration or any fever recently. And but he gives a history that he had a trauma to his right leg, 1 week back. But he did not take any proper consultation for that. He opted to only taking a bed rest. But still he had a swelling of the right leg. And for the last 2 hours, he is having breathing difficulty. So as I told you, this is the targeted history. This is given by the relatives. So it is a sudden onset, right? It's only 2 hours. It's a sudden onset breathing difficulty in a patient who is having a background of coronary artery disease. Then after the targeted examination, we find his cardiovascular system. S1, S2 was present. There was no added sounds. Bilateral air entry was present in both sides. There was no added sounds. And trachea is in midline. So this is what we have. So we have a patient with a sudden onset breathing difficulty in a patient with coronary artery disease with not much findings in the lung. Okay, so here comes the next step. So as I told you, in emergency, when your targeted assessment and initial stabilization is over, we should ask for the relevant investigations. So what are the relevant investigations will you send in a patient who comes with respiratory distress? So obviously, any patient with respiratory distress ask for an ECG, whether it is cardiac or non-cardiac. Next thing is chest X-ray, bedside chest X-ray. It can identify most of the things. Third thing, definitely do an ABG, acid-base gas analysis. So it can find out hypoxia, it can find out hypercapnia, type 2 respiratory failure. And in addition to oxygen and carbon dioxide, it can look for bicarbonate level. Because as I told you, non-respiratory, non-cardiovascular causes of respiratory distress mostly comes to be a metabolic cause of breathing difficulty. So any case of acidosis can cause breathing difficulty. Like example, a DKA, diabetic ketoacidosis, uremic acidosis. A patient with CKD, just by acidosis, he can come with a breathing difficulty. He may not have any other lung cells. So ABG is very important. So I think these are the three main investigations which you must ask in a thing. And in the recent trends, ultrasound of the lung. So even if ultrasound of the lung is not available, from a basic perspective, at least these three investigations must be done. Suppose if ABG is not available, at least you can pick most of the things by the ECG and X-ray. ECG can identify most of the cardiac things. X-ray can identify both cardiac and respiratory things. Suppose if lungs is clear and these two are normal, then think of a metabolic or a few other rarer causes of the breathing difficulty. And then comes your routine investigation. You can send for a complete blood count. You can send for a CRP, renal function test, liver function test, sepsis screen you can send, cardiac enzymes you can send, whether the patient had a MI, CPKMB and troponin assessment, troponin T or troponin I. ProBNP. If ProBNP is elevated, the cause of breathing difficulty is a cardiac cause. You can send a D-dimer. D-dimer will be elevated in the condition called as pulmonary embolism. So I'll tell you the causes shortly. And maybe some people send procalcitonin. If procalcitonin is elevated, patient is having a bacterial pneumonia. So CBC and CRP can identify infections. RFT can identify patient is having a renal failure as a cause of breathing difficulty. CPKMB and troponin T or troponin A can identify myocardial infarction as a cause of breathing difficulty. ProBNP can identify heart failure. D-dimer can identify pulmonary embolism. So these are very important investigations which you will send. So when they're pricking in the first prick, you can send all these things at the same time. So this finishes the assessment and the investigations. Okay. Now I think we'll come to the important causes and how to proceed to the next step. So what are the respiratory causes of breathing difficulty? So now what we'll do is I'll be just mentioning a few causes, what will be their features, how to identify and how to treat. Just 30 seconds for each cause. So COPD, acute exacerbation, how will the patient present? Usually he'll be a male, elderly male. I'll just write it down. So usually they are males, elderly males, who usually have a history of chronic smoking, and they may usually give a chronic history. Suppose even if they don't give a history of COPD, you know the clinical definition of chronic bronchitis, cough with sputum production for 3 months in a year for 2 consecutive years. So they'll give a long-term history of cough or wheeze or expectoration. So they may give a long history. And will it be a sudden onset of breathing difficulty or a gradual onset? Usually it will be gradual, because it doesn't start off all of a sudden. They may have some fever or infection recently. That would have increased. So usually it is gradually develops over 2 to 3 days. It's not sudden. So this is the history, and usually associated with expectoration. There may be some hemoptysis, cough. That will be the history. On doing a targeted examination, trachea will be in the midline. They may have pursed breathing, as I mentioned already. They may have cyanosis. So bilateral air entry will be present. They may have bilateral wheeze on examination, and cardiac examination will be usually normal. ECG, I think nothing much specific will be there. X-ray, we have the typical, right, hyperinflated lung. Hyperinflated lung. tubular heart, because when the lung enlarges, it will make the heart smaller to appear in the X-ray, and flat diaphragm. So how will you treat initially? Just by giving bronchodilators. So you can give a nebulizer